بسم الله الرحمن الرحيم. مستر تشيرمان، دير بانل، بشكر الاستاذ الدكتور سيد عبد الحميد والاستاذ الدكتور حمدي تمام، ربنا يهديهم كده ويصالحوا على بعض. وبشكر الاستاذ الدكتور هاني موافي طبعا على المحاضره. هو ده بعد كده هيقول لي انت مالكش لازمه، هياخدوا مني حساب لفندق دلوقتي. هو طبعا الدكتور هاني قال البيزكس بتاعه المانجمنت اوف كومبلكس فود ديفورميتي، وانا اكوردنج تو الريكومنديشنز بتاعه الجمعيه في كلينيكال ميتينجز انا بقدم كيس بيست برزنتيشن عن الابليكابل بقى اللي الدكتور هاني قاله. انا عندي حالات complicated شويه، انا مقدم 3 حاجات. whenever you find it boring or time is over just stop me يعني. أول عيان neglected bilateral talipes equinovirus، والعيان ده جالي من 20 سنة تقريبا، وكان هو من هنا، وكان عنده تقريبا 17-18 سنة، كان خلص المدرسة وكان داخل الجامعة. his family recognized that he should not go to the university with these feet. Suddenly after 18 years of age لقوا ان المشكله دي ما تخليهوش ينفع يدخل الجامعه. هو ماشي على رجله تماما، بيعمل كل الاكتيفيتيز بتاعته وهو ماشي على رجليه بالطريقه دي. كان للاسف ده كان فيلم فيديو بس is not working. He walks like normal balanced بدون اي aid. This is at the operation time. You can see that he's walking on his talus. This is the talus. وعشان كده هي equinus يعني لأن الحصينة بتمشي على التالس. This is the talus protruding. We started with the right side, and this is the X-ray. It's very complex. We can see the cavus, all components of complicated, complex food deformities. And this is immediately post-operative. We can see here, this is what is called a Borish frame. It is a non-constrained frame. It is a recommendation of Abu Rish Hospital where they put no hinges at the points of correction. The hinges only fix it to the motor units. So we can see the hinges here, 2 motor units, because the tendo Achilles was tight. I usually use 1 hinge, 1 motor unit posteriorly, but here, because it was very stiff and tight foot, 2 motor units posteriorly and 1 motor unit medially to correct the forefoot adduction. And gradually I started to correct the hind foot and adduction of the forefoot starting with. And after correction of the adduction of the forefoot, I've changed the configuration of the frame and applied this bridge, this long bridge connected to the proximal ring. And why it is that very long bridge this way? In order to pull the forefoot up to correct the cavus deformity, and to avoid collapse of the metatarsal bones. That's why I put that very long arch, very long bridge anteriorly. So when the forefoot is pulled, it's pulled away from the hind foot. So it avoids collapse and crumbling of feet tarsal bones. This is corrected forefoot. We can see here, this is a very important point. I would like to, we can see here clawing of the toes. Well, I don't consider this is a problem. We can avoid clawing of the toes if we put K-wire in the toes at the time of operation, but it's very cumbersome for the patient to have 5 K-wires in his toes throughout the month of the correction. I leave them to crumble, and then simply at the time of removing the frame, I adjust, straighten the toes, and they get straightened. And simply, if it doesn't get straightened, I do percutaneous stenotomy, and that sorts the problem out. So this is after removal of the frame, and the foot is now plantigrade and walking on it. We can see the left side is still walking on the talus behind, and then this is the left side, the same scenario. medial motor unit to correct the adduction, and the forefoot frame with a long bridge to correct the cavus, and posterior motor units to correct the equinus. This is after full correction. We can see the right foot is wearing normal shoes. And this is after removal of frame and lengthening and correction of the toes. And now we can see both feet are plantigrade equal, almost equal. And he started to, he's wearing normal shoes. الكلام ده من 20 سنة، هو اشتغل مدرس واتجوز والحمد لله is living a normal life. And a second case where the tibialis posterior dysfunction, I'm not sure about the cause of that massive deformity. We can see here a quite vulgus deformity of the right hind foot. And in X-ray, we can see this is a calcaneum abutting the fibula. The calcaneum has been translated from behind the talus, and the only thing stopped the calcaneum from escaping from that foot is the talus, the fibula. The fibula stopped the calcaneum. This is the X-ray, is a CT of the hind foot, and of course the subtalar joint it's damaged. But to do open reduction and bring the calcaneum beneath the talus is not easy job to be done. So I've started to treat it as if it was deformity. But this is a constrained frame where I have put hinges medial side in order to make them like a fulcrum, which the hind foot rotates around it. And we can see here the bed of this is where the calcaneum was landed and impacted the fibula here. But now the calcaneum is beneath the talus. And I removed the frame at that level, put the patient in a cast. And after about 4 to 6 months, I went there again and I've done subtalar arthrodesis. At that time, I used to do staples. I don't use them at all now. But it worked, and the subtalar has fused, and the patient is walking now like normal. My third case is an 11-year-old male patient who again was first time to present to orthopedic doctor when he was 11 years old. And this is how his foot looked like. It's a congenital constriction ring, affected both the foot, toes, and a trial of operative correction of the constriction ring was done when he was young, but it didn't help to avoid that deformity. This is the only case I have done osteotomies for him. Congenital constriction rings. This is X-ray of his foot, sorry. This is only one foot. And as is again at the time of operation, another Abu-Rish frame, non-constrained Abu-Rish frame, where is motor unit on the medial side. And I can see here one motor unit on posteriorly, posteromedial, to correct the equinus and inversion of the calcaneum. And we can see here there is massive rotation of the forefoot. I didn't address that rotation before, and then at the beginning, sorry. And then after correction of the adduction and equinus, and this is at the course of correction of the inversion and adduction of the forefoot. This is how the corrected forefoot. This is only one simple osteotomy at the mid-tarsal level. And then again, the pulling up of the forefoot to correct the cavus and correct the cavus deformity. Now the foot is plantigrade and more or less can walk in it. And this is when he was wearing identical shoes for both feet. Thank you very much.